Hello, everyone. Thank you for those of you that are tuning in to watch this. We are here with Janice Finley. She is here today to talk a little bit about her life and her research and her work. Janice is a registered nurse. She also has her master's. She's a PhD student right now. She is a Pierre Elliott Trudeau Scholar. And she is here to share a little bit about her life. So, Janice, thank you so much for coming today and talking to the students. Why don't you tell me a little bit about yourself, and I'm going to share your slide deck here.
Yeah, sure. Thanks for having me today. Yeah, so I'm a PhD candidate at the University of Victoria, and I've worked as a registered nurse for 11 years now, mostly in the areas of public health. So, and more so in the last, actually, the majority of my career focused on sexual health. So, I've always worked as a sexual health nurse, and that was always very separate from my experience. I live with chronic pain. And then in my master's research, I decided to blend the two. So my interests in chronic pain as well as my interests in sexual health nursing. And so my master's looked into how identity is shaped in women aged 18 to 29 that live with chronic pain. And that kind of kicked off my interest in disability studies. And so here I am now. My PhD research looks at healthcare providers and how they do or don't accommodate disability in the context of sexuality. And then I also will be interviewing patients and their sexual partners about their experience with chronic pain and sexuality. So, yeah, lots to get into. What
Yeah,
else?
lots of great
Yeah,
stuff.
yeah.
Maybe what I'm going to do is go to the next slide here, if it's going to let me. Oh my goodness. Hopefully no one has epilepsy. Okay. I stole some photos from your website and your Instagram. And I think maybe what we would call this is what people see. Do you want to maybe describe a little bit about who you are as a person? What passions do you have? What do you do with your free time?
Yeah. Well, I've always been really active and outdoorsy, as you can see. But it's been a struggle. So, like, my journey with pain started 2006. So I would have been like, I don't know, 14-ish. And nobody really knew why. I was really into playing soccer at the time. I loved running. And I had to quit all of that because I was in too much pain and nobody knew why. And then, then I would pick up another sport that could work for my body. And then sure enough, something would come along where I would get injured and they wouldn't know why. And I would have to give that sport up too. So it's always been, it's hard on like identity because I thought I would be who I am when I was younger, and then I'd be able to do all these things, and then you can't. So there's that kind of lost identity, like current but also future. So I have Ehlers-Danlos syndrome as a connective tissue disorder where your body doesn't make or process collagen properly. So what it means is my joints dislocate really easily, and then I have a lot of systemic issues like with my organs because that has collagen. And then I get a lot of like chronic pain, so constant muscle sprains, tendon, ligament tears. I'm actually sitting on the floor today because it's more comfortable for me because sitting in a normal chair hurts too much. I'm wearing my wrist brace. So I've always been really active, but it's kind of seems like I've just kind of lost one thing after the other over the years, but I still manage to do some of my hobbies. I still can rock climb. Some days I can't. And if I have to have a certain procedure or I've had a surgery, obviously I have to take time off my sports and I always have to be adapting what I'm doing. So some days I can ski, some days I can't. I just never really know what my body is going to be able to do, but I'm still able to hike sometimes, climb, bike. It just really depends where I'm at with my body and what's going on. So there's a lot of uncertainty, and that can be really, really hard as well when you can do something one day, but not another day.
I mean, first of all, I think you're probably one of the most athletic people I know. I like seeing you on your Instagram and the things that you do. Like rock climbing is like one of the most like athletic things you can do. So I think this perception of you, like I think if people didn't really know that you were living with EDS,
Mm-hmm.
that they would just assume that yeah, you're just like super fit and this is like really easy for you and like that's just the type of person you are. Whereas, oh my gosh, these slides, not this one. Oh my gosh. Okay, here we go. This is what I'm so sorry for everyone watching this. I wanted to call this maybe what people don't see, right? So like
Yeah. Yeah.
when like even just like maybe if you weren't wearing your wrist brace today, but I
Yeah.
think when people take a look at you, they see a young woman in like early career, um, you know, doing really well, and then like what kind of is going on around in the background?
Mm-hmm. And that's kind of why I started my Instagram, honestly, because I want people to be aware and see what you don't see every day when, I present normally, and normally as in able bodied, but really I'm not. And I need a lot of accommodations and procedures. So, I mean, I would say on average, I probably spend 15 to 20 hours a week at either medical appointments, getting treatments, procedures, or like doing physiotherapy. And so it's a lot to juggle when you also need more sleep. You get fatigued easily. Like trying to be a full time student and manage all of this is really, really difficult. So, yeah, I guess in the middle, that's some injections I was getting to help try to stabilize ligaments in my wrist. On the left, oh, yeah, my beloved knee crutch. Guys, if you ever break your foot, which I hope you don't, I walk. It's a game changer.
You
Basically,
were even doing like some intense hiking and
I
bouldering with
hiked
that. You
with
were like
that
the
thing.
bionic woman.
That was crazy. So that's where that one actually was, I had an accident. That wasn't, I've had three, no. Okay. So in the last 5 years, I've had like five major surgeries, I think. So three foot surgeries where they've had to reconstruct my bones. One of them was from a climbing accident. So that's the one on the left. But I was like, oh, I've been here before. I've still got all my knee scooter and my knee crutch and my forearm crutches. And the thing with Ehlers-Danlos syndrome is like the next position is the best position. So like I can't use regular crutches because they like cause nerve damage in my armpits and I already have nerve problems in my arms. So then I'm like alternating between forearm crutches and my knee scooter and all the things so I don't get any sort of new repetitive strain injuries. But yeah, so on the left is after I shattered my calcaneus, my heel bone. I fell 30 feet rock climbing and they had to reconstruct that. But the worst part was it was 9 months after I had just had reconstructive foot surgery on that foot because of my Ehlers-Danlos syndrome. So it was a really hard year, like only being able to fully walk for like 50% of the year. It was really difficult when being active is so important to me. And then, most people are like, oh, well, then you just do more upper body. But it doesn't work because I'm prone to injury. I have issues with my arms.
Right.
That was a hard time that year, but I came through and I'm climbing again ish. I'm not very good at it because now I have a lot of wrist problems that I'm dealing with, but but I'm always like, you know what? As long as I say any climbing is better than no climbing for me because I used to be really competitive and it'd be like, man, the level that I can climb at now, I'd be so embarrassed about years ago. But I'm like, you know what? It doesn't matter. I'm still getting out there and finding ways to be active. So yeah. And then on the right is an x-ray of my right foot. So I think I have eight, one, two, four, five, I think I have six. No, I have three in the back. I've got, I think, six pieces in there. So the front X of the screws was from the previous surgery, and then the back stuff is from the climbing one. Um,
Wow.
and they said I probably wouldn't be able to climb again because they weren't sure if yeah. Oh, they also said it would take up to 2 years to heal from the climbing accident, and it took me like a year. So perseverance.
Yeah. Yeah.
But it's not about overcoming disability because my disability cannot be overcome. And that's really important. I think people think, oh, you can do something. It's like, there is no cure for what I have. It's just treatment management. Um, and it gets worse as I age because of all the arthritis and stuff and like accumulation of injuries. So then I've also had doctors that are like, well, you shouldn't be active. You're doing there. It's either like you're too
Damage.
active or you're not active enough. And I'm like, the thing is, being active is what keeps me high functioning because then I have the muscle strength to support my joints and
Right.
promote healthy aging.
Yep.
So the irony is, as much as I can develop injuries from being active, it's also keeping me from declining more of my function.
It's kind of like a catch 22.
Yeah.
It sounds like, and this kind of segues a bit into, I wanted to know, like, what are some common kind of misconceptions or stereotypes that you face kind of living with your disability and also being like incredibly busy, like doing all of the things, like being active, being an incredible student, being a nurse. What kind of like misconceptions or stereotypes are you finding with like coworkers or healthcare providers or even friends and family?
Well, first of all, it's challenging because in some ways I can hide my disability because if I'm not wearing my braces, again, I present able-bodied, healthy, vibrant. And so it's easy for me to not tell people and I can hide it. But then the catch 22 of that is then they don't realize how much of a struggle it is to function with my disability. Because there's still stigma around it. And so, in certain contexts, I don't tell anybody. But then they don't understand when it's like, no, I can't like go to the break room with you on my shift and just sit for half an hour. I have to go do my physio so I can like manage the rest of my shift, or I need to go lie down. So then a lot of people, I think, either think that I'm exaggerating when I do that because they're like, well, you're able to do all these things, or they're like, well, you can't be that disabled. So there's a
Mm.
lot of, even within the disability community, there's still ableism because it's like, oh, you're not disabled enough to be in our community, or even internal ableism where it's like, oh, I should keep those supports for someone else. Like I financially could do without, or that accommodation. But there's the scarcity of resources for disabled people in our public system as well. So it's kind of like, okay, this would make my life easier, but I think someone else could use it more. And so then there's that internal ableism as well. So a lot of disbelief, I think, and people are like, well, you look healthy, therefore you are. Well, no.
Yeah, I think, you highlighted kind of perfectly the juxtaposition of, presenting well and still, doing the things that you want to do, but then that kind of leads to some questions being raised about, well, if you can do them, like, is it really a big deal? And then I think there's probably, probably had to have a battle with like coming to terms and accepting, your limitations and accepting health. Like when I did my research and I spoke to women living with fibromyalgia, I was asking people about, thing accommodations or accessibility aids that would make things easier for them. And they kind of said something similar to you, which is, well, I could go without them, but I have more suffering and more pain if I don't.
Yeah.
But then not being disabled enough. And then I think also kind of internally being worried about, like you said, maybe taking away from someone else. I think the greatest example I can think of this is like a accessibility parking permit
Yes.
and using that. And then, maybe you're not wearing any braces that day. Maybe you're coming to speak to a classroom and you're dressed up and you get out of there, right? Like, what do people see? And what are maybe some quick judgments that people are making?
Yeah. 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 I mean, and that's even within like other disabled people too, right? Where, and then I do get penalized for being high functioning sometimes,
Mhm.
especially in the medical system as a patient, I find, where it's kind of like, well, but they don't see how hard I work to stay this high functioning. Like I said, it's a part-time job. But yeah, absolutely. A lot of assumptions around she's, making it up or exaggerating if I do talk about it sometimes, because like I said, I can be perceived as very high functioning. Yeah.
How would you say some of these things kind of influence your relationships in the healthcare system and the healthcare providers?
hmm I see it positively now. It was I so for me, I actually it took 15 years to get diagnosed, and that was very frustrating. I had a lot of misdiagnoses, a lot of dismissal. A lot of, oh, it's anxiety, oh, it's trauma, oh, it's just chronic pain, push
Mm,
through. And I did push through, and now now I'm suffering as a result, because it turns out actually there was something wrong with my body, and I was creating like biomechanical problems by continuing to push through pain. Like my body was telling me something, and I was like, well, it's just pain, I can put up with pain. No, in my case it's not. So that was a really difficult journey, getting a diagnosis that explained what was going on in my body. Because yes, chronic pain can be, like primary chronic pain is a diagnosis in itself. That's a disability in itself. And in my case, something else is causing that pain, and we didn't know what that thing was. So a lot of misdiagnoses. And so it was very frustrating to be seen. I was young, like, despite being a healthcare provider, like I was in nursing school and then became a nurse. You're 20 and trying to figure this out, and you don't know anyone else that's going through what you're going through at your age. So very isolating. And then to have healthcare providers, right, kind of dismiss your experience. Oh, well, you look healthy, you're young, you're doing well. So sometimes there's like, there's this line of, when you go to a medical appointment, you want to look um, like you're doing okay and you're not like malingering or exaggerating things, but you also want to be able to show that, no, like I'm suffering, this is a problem. It's this kind of balance. But then if you show off you're too high functioning, then they don't believe you. Um, so I trust with medical providers, but I'm at a point where I have a great medical team. I bring my research papers that I find, and I'm like, hey, what do you think about this thing? Would this help me? And so now I see it more as like an educational opportunity for healthcare providers that don't understand. Um, but advocating for yourself continuously can be very tiring, and that's an extra layer on top of living with a disability. So those advocacy skills, like, I have developed because of my journey. And so now I'm able to not, I'm able to speak up in a way that's not going to affect my care, but educate healthcare providers as well as a patient. And obviously I have insider knowledge because I'm a registered nurse, I'm an advanced practice nurse, like, you know.
yeah, I wonder what things would look like if maybe you went to school for something else and you weren't a nurse. Like
Yeah.
what would the advocacy look like? I mean, I can't help but wonder, being a woman and being young,
Yep.
how that plays into how you were treated in the healthcare system. I think, especially during diagnosis, but I think continued throughout, because I wonder, if you were an older adult when you started maybe first experiencing these things, or just in general, I think people with disabilities, I think being young and not having things that are outwardly visible and being a woman, I mean, there is research out there to show that women's pain is not treated the same as men.
Yeah. Yeah. And that's why I did my master's research, because I recognized that in my own personal experience, and then decided, I was like, okay, academically, we need more awareness around these issues. But a big misconception is that only older people have chronic pain or disabilities, right? But no, it's across the lifespan.
Sorry, I was trying to
Woof.
nonchalantly change the slide. I can be completely honest, I'm not sure what's going on with this. But I was going to say that's a great segue for you to talk about your professional side, your academic side. We've talked
Mhm.
about, what you live with. And well, first of all, I'd like to say that the bottom picture is actually where I met Janice.
You might
I
have
think
even taken that picture. No, I don't know if you did, but somebody did.
I'm not sure, but anyway, so I met her at I think it was at the 2023, where was it, 2022 now?
I think it was 2023.
Yeah, okay. The
I think.
2023 Canadian Pain Conference. And Janice was presenting her master's research here. She also won the poster presentation. I was so excited for her. But yeah, I'll say, I did want to also say, like, when I met you, I think the first thing that I really enjoyed was that we kind of connected a little bit about, our chronic illness and, being young women. And I think we were making some kind of jokes about, we're at a pain conference, but we were,
Yes.
felt like the chairs are really
It was
uncomfortable.
not an
Like,
accessible conference to
it
me.
was not
Oh.
super accessible. So, some work there. But maybe I'll let you talk a little bit about, okay, so what is your passion, how did it lead to this research, and what are you focusing on now? Like, what are your hopes will
Mhm.
come from some of your research?
I think I've always been passionate about working with young adults. And so that was how I got into sexual health. And then working in sexual health made me see how many young women live with chronic illness or pain that isn't recognized, or they haven't been diagnosed. They don't know necessarily like where to go, how to like navigate the healthcare system to get the help that they need. And the story that will always stick with me, I was working as a sexual health nurse one day, and this woman starts telling me about her like just generalized chronic pain and how she's trying to like find out why. And I listened to her story, and then she goes, "You are the first healthcare provider that has ever listened to me tell my story." And that just hit really deep that, structurally, there's many barriers. Healthcare, there's many reasons. It's not just the healthcare provider's fault. That really stuck with me. And so my master's research, I looked into the experience of living with chronic pain, how it affects identity in emerging adult women. So, like I said, women age 18 to 29. And it was really about hearing their stories and their experiences. And it was really remarkable that, what came out of it, the findings very much aligned with the research that we do have, which is that young women are, their pain is frequently invalidated, dismissed, misdiagnosed, attributed to anxiety, but living with a chronic illness often causes anxiety because you're trying to navigate all of this in a world that isn't set up for it. And of course, there were some sexuality themes that came out of it. And so I decided in my PhD research now to merge my two passions, so chronic pain disability advocacy and sexual health. So looking at disability and sexuality together. And so the last couple of years, I've really been diving into disability studies and sexuality. So it's interesting that like disability is stigmatized, sexuality is stigmatized, and then you put them together, and it's
Just
very complex,
compounded. Yeah.
very complex. And so that's my research now for my PhD is looking at what happens when so what I've observed and what there's not a lot of literature on it, but what I have found is that chronic pain clinics themselves don't typically address sexuality or sexual health in the way that's needed, especially for young people, because there is that perception that chronic pain is something that only affects older people, or like, oh, you have a disability, you have chronic pain. Well, sex isn't important, but it affects your relationships. It's part of identity. Everybody has a right to, if they want to, have a healthy sex life and really celebrate their sexuality, even if it doesn't fit this heteronormative, able bodied idea that we have about sex is just for young, beautiful people that are able bodied kind of thing, right? But no, people have sex across the lifespan. It's a normal, healthy part of being human. Um, and as soon as you add the disability piece, it's very, very complex. So, and then the other interesting thing, and this is kind of what led me to my PhD research, is that working in sexual health clinics, we don't address pain. The only type of pain we might address is like specifically sex with pain. And most of the research, when you look at chronic pain in sex, is just that. It's like, well, it's, pelvic pain with sex. But chronic pain affects your sexuality in so many more ways than just, okay, you have pain with sex. Because sexuality is more than the act of having sex, right?
I think, yeah. And it sounds like, what people are experiencing is that, they're only ever getting kind of one part of, their
Mm.
lived experience or their identity. So like you said, like if they're going to a pain clinic to treat their chronic pain for their disability, but then maybe they want to go there and talk about sexuality and things that would be like their sex life, like how they could improve that living with this condition. And then the pain clinic's like, yeah, I don't deal with any of that. But then public health and talking to people about sex, they might not have the resources to talk about
Yeah.
what that's like living with disability.
It's very much focused in sexual health clinics on, harm reduction, because that's what we have time for. That's what we're trained for as registered nurses, is that very much biomedical piece, like STIs, pregnancy. Okay, we can do that. But very much this kind of idea, again, not having the resources to really address, like be able to talk about that. But like, the idea that we're not sex therapists as sexual health nurses, but we are that, how can we provide holistic care, really? Yeah. So
I
it's
think
very divided and fragmented. And then just lack of awareness and education and resources for both disability and sexuality in healthcare, right?
I think you're right. Like I think that lack of resources and, specialized training, I think like organizational constraints. Some people in my class were asking about, how do I provide the best care if like, I want to do something that's not within my means, like maybe that's the time that you can give to someone, or even what you were saying, like if you're working at a sexual health clinic and you're kind of limited in what you're supposed to be talking to patients with or helping them with, what do you what are some kind of things that you kind of keep in your kind of back pocket for when you have patients requesting things that you either, you know, can't do the best job of due to, resource constraints, or maybe even a little bit more of, maybe you're not supposed to because, maybe you're getting from, your managers that that's like a little bit out of your, I don't
Mm,
want to say scope yet, but, you know,
right. Kind of the mandate of the program. Yeah.
yeah.
So I think having a strong foundation, first of all, is like knowing what our professional standards are. Like I practice in Alberta, so knowing what your like I don't know what it's called in
Like
Manitoba.
your governing body, I
Like
think.
yeah, like when I was a student, it was like a little book, and it's like, okay, like as a registered nurse in Alberta, this is what you have to be like.
Oh, like your practice competencies, maybe?
Yeah, yeah, yeah.
Yeah.
Like what are your professional standards and practice competencies, because legally that's what you are required to provide.
Yeah.
And so knowing that, and then it's balancing that with obviously like also keeping kind of my foundation for practice is like the Canadian Nurses Association code of ethics. So it's like, that's like at the core of what I do is like, okay, how is this like ethically match the code of ethics, because that's what we're required to practice as well. So managing your like practice standards or professional whatever you call it, and then the code of ethics, and then also your organizational or institutional like standards. So what am I supposed to be providing under that program, and then I kind of find ways to like, not that I go rogue, but once you legally know, okay, I'm not going to get into like deep water, hot water. If I do this thing, I do it. Depends what it is, obviously. So, um, and that comes with clinical experience, like knowing when you can kind of bend the rules and it's okay because it's for the best interest of the patient. However, it's not going against any of those standards, right?
Yeah.
Or advocating like within to your manager within a program and be like, well, no, this actually what you're saying contraindicates like this standard or our mandate of the program. um, but that takes a lot of experience. And then if I really can't provide something to a patient, I'll be honest with them. I'll be like, I really wish I had time to have this conversation with you. Maybe I'll, have a much shorter conversation and be like, hey, this is where you could go. Or if you want to come back, we can follow up on this. Or I think you'd be best suited at you go to this clinic instead. I'm just, I'm sorry I can't provide that service today. And I'll be honest with why, you know?
Yeah, I mean, I think resources are great too to be able to say, like, I
Yeah.
don't have the time or I'm not really able to get into that, but here's a really great resource, like being aware of some of those things. I think, you know, sometimes I hear from nursing students that, they don't really, how is nursing political and why is it important to know like governing policies, not just, I think, from a, you know, the governing body, but I think also Canada. Like, do you know what like human rights are in Canada and like what are our rights and freedoms? Like, it talks about basic human rights and, accessibility for marginalized groups. And, I think it's important to have some of that in the back of your mind to when you come across maybe something that's like a bit morally ambiguous or you have a bit of a dilemma to be like, okay, here's the tools to go up and talk to my manager and be like, you know what, we are not
Yes.
following, we are violating someone's rights and freedoms, right? Like this is a
Yeah.
governing law that our country uses. I can think of, I actually, so politics is not one of my strong suits. So when I was brushing up on it and reading about, the 1982 Charter of Rights and Freedoms, they originally weren't going to include a section on accessibility.
Yep.
And there was actually a group of, I think it was fairly small, like 15, 20 people that went down to Parliament in like 1980 and were protesting. And these were a lot of people that were living with disabilities,
Yep.
or, maybe they were a caretaker. And they were like, accessibility is a basic human right. And they basically forced the hand of the government. And that's why we have Section 15, which talks about accessibility. So, like, I think when people talk about political action and as a nurse and, weaving in, advocacy, a small group of people can really make a huge difference because that's now a standard for the country.
Absolutely. Yeah. Nursing is political. Anytime you advocate for a patient, you're changing, you can change the system even just by that, right? Absolutely. Yeah. And
Yeah.
then I think learning not to be afraid to speak up to your manager. Like that's part of the reason that I decided to go back to grad school was, I love being a frontline nurse and I still maintain my practice and I still do practice, but I wanted to have a greater difference in in nursing, and shape things. And I was like, okay, frontline's great, but I need to be a person at that seat of that table making these policy decisions. And so I never thought I would be there because I'm also not a very political person, but I just felt so strongly about what I was seeing and the changes that I think needed to happen in our healthcare system. And the way that that happens is policy changes. And then that trickles down into your nursing practice and how that informs the what your program provides, what the unit provides, what you're allowed and not allowed to do in a hospital as a nurse or in the community. So, a lot of people, I think, I didn't realize for a long time when you think about it, like what you do as a nurse comes from up here,
Yep.
and that they
Trickles
make
down.
these policies that trickles down. So really, you're affected by politics. And so I was like, well, why not be one of those people up there, right? Um,
Yeah. I mean, I think a lot of nursing students, and I can even think back to myself, like we really wanted to know, like, what's the right way to go about this. And like, I think for almost anything, there is no cut and dry right way to go about something. Like,
yeah,
unless you're specifically talking about, a clinical skill that has to be done a certain way for patient safety. I think the way that you interact with human beings and the world, I think it varies, it's subjective. And so that's why we kind of teach things like advocacy and human rights and diversity and accessibility, because when you know about, knowledge is power, when you know about these things, you can start noticing, you can speak up. And again, I was talking a lot about humility, just to say, I don't know anything about
yeah,
this. Would you mind please telling me, how best I can help you today? Or, I can see you're struggling with something like this, or you're using this accessibility device. How can I help? Do you even want help? Right? Like, even
yeah,
just the assumption of,
yeah.
they want me to help them, maybe they don't.
That's so true. And that goes for all aspects of healthcare. Like, I work with a lot of gender minorities or sexual minorities, and I don't have personal experience with that. And so I'm always like, ooh, I don't want to like say the wrong thing. But what I've learned is if you're approaching it with genuine kindness and curiosity, no matter whether it's a disability or a sexual identity I'm like not that super familiar with, the patients receive it really well when you're like, hey, like how do I don't know, can you help me understand, I'm going to do my best here. And I think you spoke to a good point about maybe they don't want help. So always like being aware of that and asking, because I have a friend who she's a wheelchair user and she gets so tired of people like she's like going down the street at a crosswalk or waiting for a light and then people will just like grab the handles on her chairs and start pushing her with
Oh,
like strangers because they
oh
think they're
no.
helping her. But
Yeah, that's not consent.
she's like put spikes on the handles on her wheelchair because she's so tired of that. So
Oh, I actually love that though.
understanding, yeah, I think just being, yeah, just that humility piece. Hey, yeah, absolutely.
Yeah. No, I think, there's so many, I think, like little intricate dimensions within
Yeah,
all of this. And I
yeah,
think even us, right? Like even though we both live with a disability and chronic pain, even though, we're doing research and having more awareness and reading about things like, you know, I can have expertise in an area, but I am never going to promise to know what's best for other people or oh, I'm an expert here, this is definitely what we should be doing. Like at the end of the day, consent is really important. And I think like meeting patients where they're at, right? Like what
Mhm.
are kind of checking your judgment at the door, like are the decisions that you know I want this patient to go through with, like is this just based on what I think is best for them, or am I really making these decisions with them and doing what they want to do?
Yeah, that was a difficult lesson for me to learn because early on in my nursing career, it was very much like everything has to be by the book, which is good because you don't want to make a mistake. But then accepting that sometimes a patient doesn't want to follow that care plan. And then that's patient centered care is kind of meeting them where they're at and figuring out, okay, this is what like we recommend, but what like how can we help you and support you and being able to like kind of like translate that kind of like between the patient and what you're supposed to be doing and kind of
Like kind of compromise a little bit, or
yeah,
you want to advocate for safety, we always do, right? Because sometimes
yeah.
the
And
decision that
legally you have to,
legally you have to, right, if it's
yeah,
gonna maybe cause some like ill effects to patients.
yeah.
But at the end of the day, and I think that's also something that's hard to learn and comes with time and experience, to then take a step back and be like, okay, like that was upsetting for me because they ultimately decided to do something that, I didn't agree with, or, that I didn't want for them or I didn't recommend, but, I'm here to help them.
Hmm.
And so, yeah, like that reflection piece, like I think sometimes we lose that. Like it's really
Hmm.
important in nursing school. And then all of a sudden, 5, 10, 15 years down the road, when we're in like COVID, I think was a great example of like, were we really taking the time to do some reflection and, you know, make sure that I think that we're emotionally well and in a good place.
Hmm.
I hear people saying, oh, well, what if my patient, is rude or mean or in a bad mood? And yeah, a lot of people are going to be, right? Like,
Yeah.
people aren't going to present the way, they're not going to be super kind and friendly and appreciative all the time, right? So like, but that doesn't mean that we can give them any less care. Now, I mean, we have to have boundaries, we have to protect
Yeah,
ourselves,
we don't
obviously, but
tolerate verbal abuse. We have
yeah,
policies around that, but
there's policies around that, yes, but patients don't have to be happy and smiling.
no. And when we meet a patient in practice, usually we're working with them in their most vulnerable state, right? So keeping that in mind, and so I one example is I often work with partner notification with the STI program. So I will call people that have come into contact with notifiable sexually transmitted infections like chlamydia, for example. So these people, is totally out of the blue. They're like, what do you mean I'm come in contact with chlamydia? And often they're very upset, right? Right,
Yeah,
which is understandable. And so if it does escalate, I'll say, you know what, I can see you need some time. Um, let's continue this conversation later, right? Call me back when you're
yeah,
ready.
yeah, take a moment,
Yeah. And that's
um,
okay.
and validate them.
Exactly.
I would
Like
have
this is an
patients
upsetting
where,
experience,
yeah, it's okay to be really upset right now.
it's normal. You're experiencing that is normal. That's a normal
Yeah,
reaction.
yeah, or with things that happen, like, I work, my last clinical job was in the recovery room and people's surgeries would get pushed and they'd be waiting all day and it sucks
And they're hungry
and they're
because they can't
hungry,
eat.
and I'd have to be like, you're right, like this sucks. I'm so sorry that
Yeah.
happened to you. Um, it's okay to be upset. And sometimes people just need that validation.
Yeah.
Um, but yeah, so I think we've kind of weaved in through this chat a little bit about, what are some pros and some negatives, like kind of experiences you've had within the healthcare system. But maybe if you were to kind of summarize, especially because, we're going to be sharing this with nursing students,
Mhm.
what has been like the most helpful things, or what are some, positive experiences you've had with healthcare providers or nurses? Like what were they doing?
I would say validation and empathy are fundamental to any interaction that I've had that were a positive. Me being the patient in these situations is saying, And also being honest with their communication. Like, you know what? Like just saying, hey, I don't really know what's going on, with your wrist or whatever, but these are the steps that I think we should take. And we're going to try to figure this out. Or anytime I have a procedure where they're like, well, this isn't really standard. We think it's going to work. It's just like laying everything out, being super open and honest with communication and education, and then validating, where it's like, I remember the first time I had a doctor actually validate and be like, wow, thank you for sharing your story with me. That sounds really hard. And I broke down because I just was like, nobody's ever said that to me.
The bar's so low. Like the bar is so low here. Like
Yeah.
we're just looking for some human connection
Yeah.
and
Yeah.
acknowledging what they're going. And I think also sometimes people might have some misconceptions that, patients or even family members, because family members can be really intimidating too.
Hmm.
They're looking for the right answer. And then you're thinking, oh my goodness, I don't know what to say, or I don't really know what's going on. That's like a completely appropriate thing to say. And that's actually better than just like kind of skirting around it or avoiding it, to just be like, I don't know, but I'm going to find out for you. We're going to work through this together.
Yeah. And that's how you build trust with a patient, right? Is that honesty. Because I can tell when someone's trying to pretend that they know everything and they don't. And that doesn't build rapport or trust in my experience.
Yeah.
Yeah. Yeah, absolutely. And involving them in the decision-making process, like that makes is really
Yes.
important to me. And recognizing that, these people are experts in their own lived experience. You have the tools to help them. Like me, maybe they're not experts in, nursing. But they're the experts in their own lived experience. And so not taking away from that is really important.
Yeah, I think that's a really key point here. You and me are very different. We both live with chronic pain,
Yeah,
but that looks so
very
completely
different.
different. And, if you had to ask me to, or, if we each collectively kind of sat and wrote down some goals for each other, I'm sure that they would be just like completely out of whack to like what our actual life and what our goals are, right?
Yeah.
I won't be rock climbing, so that would be a not. But yeah, I think we've touched on a lot of really important things. I think we could go on forever and ever. But I'm really glad that you kind of sat down to chat with us, for those that are listening. I did just want to kind of pull up your information here,
Yeah.
because if anyone has any questions, I think you were saying you're
Yeah.
kind of happy for people to reach out.
Yeah. Or you can give them my email as well, whatever works. But you can also reach me through my website.
Yeah, shout out to your website. It's very nice.
Oh,
So
thanks.
people can reach out there. I can also include your email.
Sure.
And yeah, thanks so much, Denise.
You're so welcome. Take care.
Thanks. Bye bye.